I am pleased to introduce you to Nick Kattan, the Associate Chief of the Division of Hospitalist Medicine and Assistant Professor at the University of Florida. Nick is responsible for creating many of the order sets for our hospitalist service, and today he's going to present the approach that our hospitalist service uses when managing COVID-19 patients on our medical surgical floors. Nick, welcome.
Thank you, Dr. Southwick. You have reviewed individual videos describing how hospitalists at MGH manage the admission, treatment, and discharge of COVID-19 patients. I would like now to put all the components together in an overview on how at the University of Florida Hospitalist Services, we manage our COVID-19 patients on the medical surgical floors. Let me start with an algorithm showing how we decide on testing and hospital admission. The upper part of the flowchart deals with patients in which COVID-19 disease is suspected. Those with positive PCR are diagnosed with COVID-19 disease, and its severity is decided based on the ability to maintain oxygen saturation levels above 94% on room air. Patients with non-severe COVID-19 disease can be safely discharged home with instructions to self-isolate for 14 days. Patients with severe disease will need admission to the hospital. The correct coding diagnosis for such patients should show that they have an acute hypoxic respiratory failure from a viral pneumonia caused by severe COVID-19 disease. If COVID-19 disease is suspected, but PCR is negative, remember it has a sensitivity of around 60 to 80%, then search for an alternative diagnosis is a reasonable idea with a PCR for other respiratory viruses, procalcitonin, and lactic acid. If an alternative cause is found, then it should be addressed, and COVID-19 disease is likely not present. If the above tests are non-diagnostic, continue to explore an alternative diagnosis, like PE, for example, but it is also reasonable to repeat a SARS-CoV-2 PCR nasally and/or consider a bronchoscopy to obtain a deep respiratory sample. CT scan with ground glass infiltrates, specifically if they are peripheral, greatly increases the probability that a patient has COVID-19 disease and may obviate the need for further PCR testing. We have seen several cases of COVID-19 disease which starts as a mild disease. However, 7 to 10 days after onset of symptoms, they develop dyspnea, with nasopharyngeal samples being negative, while BAL samples being positive. On the next slide, we see the basic orders for hospital admission, which should include modified airborne isolation, which means that a negative pressure room is not required, but the use of N95 masks and eye protection are required. Telemetry both for heart rate and pulse oximetry, supplemental oxygen orders with instructions to wean as tolerated, and initial labs and daily labs that will guide the clinician on the risk of developing cytokine storm and/or thrombotic complications. COVID-19 patients have shown evidence of viral myocarditis, which initially presents with chest pain or heart failure symptoms, or it could actually only present with troponin elevation. So telemetry and troponin levels and symptom-based monitoring may clue you to the diagnosis and prompt ordering an echocardiogram. In terms of COVID-specific therapies, as described in Module 2 in the treatment section, the randomized controlled NHS recovery trial showed that dexamethasone reduces mortality by 1/3 in mechanically ventilated patients and by 1/5 in patients receiving oxygen without mechanical ventilation, but it does not reduce mortality in patients not receiving supplemental oxygen on randomization. Of dexamethasone daily for 10 days or until hospital discharge, whatever is first. There is no need to continue the dexamethasone after discharge, especially if the patient is no longer in oxygen. On Remdesivir, was given an emergency authorization used by the U.S. Drug Administration Agency in May of 2020 for patients hospitalized with severe COVID-19 disease. To date, there are 3 randomized controlled trials available. The first one was done by Wang et al. In a in 10 hospitals in Hubei, China. They randomized patients with severe COVID-19 disease in a 2-to-1 ratio to remdesivir versus placebo for 10 days. The endpoint was a clinical improvement, which was defined as a decrease of 2 points in an ordinal scale from discharge to death. They did not find any benefit from remdesivir, although the study may have been underpowered. The second RCT, called the NIH ACT-1 trial, is also reviewed in Module 2. More than 1,000 patients with severe COVID-19 disease were randomized to 10 days of remdesivir versus placebo. Primary outcome was time to recovery and discharge from the hospital. This study was unblinded early due to data showing early recovery in the remdesivir arm by 4 days, but no mortality difference was seen. The third RCT was done by Spinner and colleagues, conducted in 105 hospitals in Europe and Asia, included 584 patients randomized 1:1:1 to 5 days or 10 days of remdesivir or standard care. This open-label trial included non-severe cases of COVID-19, and a benefit was shown with a 5-day course of remdesivir, but not with a 10-day course. Some patients in all remdesivir trials received steroids, but there was no formal cross-randomization or interrogation of the treatment-by-treatment interactions between remdesivir and corticosteroids. So at the end of the day, we're left with 3 randomized controlled trials that show conflicting evidence. One showed no benefit. The second showed benefit with a 10-day course of the drug in patients with severe disease. And the third one showed no benefit with 10 days, but benefit with 5 days, but included patients with known severe disease. So now what? Based on the available evidence and the shortage of remdesivir supplies, at UF Health, we formed a task force with members from the Infectious Disease Division, the Pulmonary and Critical Care Division, and the Hospital Medicine and Pharmacy Divisions to evaluate who should be deemed a candidate for remdesivir, especially when supplies are short. So SARS-CoV-2 positive patients were assigned into 3 categories based on clinical factors determined by the task force and based on the available data, the scope of which is enough for a whole lecture, so I will try to keep it short. Suffice it to say, patients in category 3 are those requiring ventilation or ECMO, and they will not benefit from remdesivir and will not be offered the medication. Patients in category 1 are those requiring oxygen supplementation, and all trials show a probable benefit from the medication, so those ones are offered the medication as supplies allow. Category 2 are those patients which were specifically defined in any of the randomized controlled trials, so we are not sure if there is a benefit or not, but we think they may benefit from the drug. Those are patients that have low GFR, less than 30, or are on dialysis, patients that are in septic shock or multi-organ dysfunction syndrome, or patients that are requiring non-invasive mechanical ventilation. For those patients, if supplies are enough, then we offer them the medication. If there are more patients than medication, at UF, we are doing a weighted lottery system to decide which patients are offered the medication. In all the cases, the patients need to be informed that this is an emergency use medication, and they have to agree verbally to the use of remdesivir. Anticoagulation strategies will be covered in detail in the section on COVID-19 thrombosis. All of our hospitalized COVID-19 patients are on pharmacological VTE prophylaxis unless it is contraindicated. The next question is, when is it okay to remove isolation requirements for patients that are still hospitalized? Previously, the WHO recommended using test-based strategies in which 2 negative PCR tests at least 24 hours apart were required to clear someone from isolation. This recommendation was based on knowledge and experience with similar coronaviruses, including those that caused SARS and MERS. But it rapidly became clear that patients may shed viral RNA for weeks, despite a full clinical recovery. Despite this positive test result, these patients are not likely to be infectious and therefore are unlikely to be able to transmit the virus to other people. Please review the earlier discussion on PCR testing in the first section of Module 3. At least 4 studies using viral cultures were not able to retrieve viable virion particles past 7 to 9 days of symptoms, even in patients with persistently positive PCR testing. One possible outlier is a case report of a patient with mild COVID-19 disease who remained positive PCR for 63 days after symptom onset. In this patient, viral cultures were positive from the upper respiratory tract specimens only on the day of symptom onset, but were culture positive from sputum samples until day 18. He was still symptomatic when cultures were noted to be positive. Therefore, the combination of time after onset of symptoms and the clearance of symptoms seems to be a generally safe approach based on current data. As of May 27 of 2020, the WHO changed the recommendations and the CDC followed suit. The difference between the WHO recommendations and those of the CDC is that WHO suggests patients be without any respiratory symptoms for at least 3 days past the 10-day minimum requirement. So for now, in immune-competent patients with non-severe disease, we wait at least 10 days from symptom onset, 24 hours with no fever and no antipyretics, and clinical improvement before removing isolation. For any immune-suppressed patients or any patients with severe COVID-19 disease, we wait anywhere from 10 to 20 days, according to CDC and WHO recommendations. The rest is the same as for non-severe cases. In our hospital, we elected to use 20 days as a standard cutoff for any severe case, just to make it simple across the board. When is it okay to discharge a patient? Well, for patients with SARS-CoV-2 infections, meaning asymptomatic, or non-severe COVID-19 disease, meaning you have upper respiratory symptoms, but you're not requiring supplemental, or those with severe disease, meaning anybody that requires supplemental oxygen, but who are now back on room air, it is reasonable to discharge them when clinical improvement is present and no fevers are documented for 24 hours with no use of antipyretics. For patients with severe COVID-19 disease who are still requiring supplemental oxygen at nasal cannula with low flows, the same principles apply, and I would add that their cytokine storm markers should show a downtrend. You should provide them with supplemental oxygen and have them follow up with their primary care doctor within 1 to 2 weeks to determine the continued need for oxygen. Facilities, accepting facilities should not request discharge PCR tests on patients who are previously positive, now that we are moving to the non-test-based strategies. That is because we know they can be persistently positive. In summary, identify the difference between SARS-CoV-2 infection, asymptomatic patients with a positive test, non-severe COVID-19 disease, upper respiratory infection symptoms with no hypoxia, and send those patients home with instructions to self-isolate and education on red flags to seek assistance, as lower respiratory disease may lag 7 to 10 days behind the onset of symptoms. Admit any patients with severe COVID-19 disease, that is, those with oxygen saturations less than 94% on room air, isolate them with modified airborne precautions, monitor them on treat and clinically for ARDS, myocarditis, and thrombosis, start them on treatment with supplemental oxygen, antipyretics, acetaminophen is preferred over the NSAIDs, dexamethasone at 6 milligrams daily for 10 days or until discharge, and possibly Remdesivir, depending on supplies and the 3 categories we described. And anticoagulant, remember, enoxaparin is preferred when your GFR allows, and determine readiness for discharge based on clinical improvement, the effervescence without antipyretics, and you may consider using the labs for cytokine storm. They may still require supplemental oxygen on discharge. Consider post-hospital anticoagulation if their bleeding risk is not high. And finally, use non-test-based strategies to discontinue isolation when appropriate, meaning they may need to self-isolate after discharge if they are being sent home before the time of isolation is finished. Thank you very much.